Okay, so we will move on to the next person.
So he's a wonderful man. He's none other than Professor Dr. Gustavo Zubieta-Calleja. So he's the director of IPPA and president of Zubieta University, vice president of International Society of Chronic Hypoxia, past visiting professor at University of Göttingen and current visiting professor at ERA University, Lucknow, India, and American University at Barbados. He is the coordinator of research cooperation with BLDE University in Vijaypura, India. His current research mainly focuses on development and discussion of the high altitude adaptation formula and the tolerance to hypoxia formula. At IPPA, we are specialized in treatment of high altitude medical problems for newcomers and local residents. That's very great of you, Professor. And they also have all the resources that allow us to treat effectively and successfully acute mountain sickness, high altitude pulmonary edema, high altitude cerebral edema, and others. The precise diagnosis is essential in order to counter the effects of hypoxia, and successful construction of elevator for IPPA, in charge of brains of elevator with new technology. So his title for the talk is Pneumolysis, a silent hypoxemia in COVID-19, a new concept. So welcome, Professor Gustavo. Over to you.
Well, first of all, I want to thank the organizers for inviting me. I am one of them, of course. This talk is a very peculiar talk. I am going to be questioning some things about medicine, traditional medicine, and I'm going to propose some things that are, I think, fundamental under the circumstances that we are currently living. And this has to do with the term pneumolysis and silent hypoxemia in COVID-19, a new concept. I'm also a visiting professor at VLDE University. So I'm going to talk about three subjects here: pneumolysis, silent hypoxemia, and high altitude and COVID-19. Actually, silent hypoxemia, I'm going to share with Natalia if her internet comes back. So what is going on with COVID at sea level? You see, here's the alveoli and here's the capillary in a graphical way. And suddenly we have the coronavirus coming into your lungs. Now, this is very important to understand that the virus does not attack, apparently, the bronchi. You see, because if it attacked the bronchi, we would have a hypercrenia, is what it's called, a lot of excessive secretion and phlegms coming and a lot of coughing from phlegms. But it doesn't. It goes all the way in exactly to the alveolar cells. And when it goes in there, you see this photomicrograph, so many of them lying on the surface. And here you have a electronic microscope of an alveoli and a capillary. Here on the right is the alveolar space where air comes in, and on this side is where the blood is circulating, of course, and oxygen has to go through. And the beautiful talk given by Professor Miserocci explains the importance of low water here for oxygen transport and carbon dioxide diffusion outside, but also shows the importance of this matrix here, the interstitium. Fundamental indeed, to maintain the structure of the lung, that if you spread the surface of the lung, it corresponds to approximately 90 square meters. It is like a tennis court. But why do we have such a big surface area? Because it depends on the size of our bodies and the requirement of oxygen. There are physical limitations from the fact that the laws of physics have to be maintained. So a certain surface area is fundamental. And at high altitude, we have a higher lung volume in order to compensate for a low barometric pressure. So what happens when the COVID attacks? You know that at sea level, there's a lot of ACE receptors, and the virus comes to your lungs, and with the beautiful explanation by Hamid of the spikes that even surprised me that they have this mechanical movement that makes them come exactly to the joint area to introduce themselves like an alien, to introduce the RNA inside the cells. Why does a virus want to do that? Because this is his mechanism of reproduction. I have written an interesting article in our previous conference that the coronavirus has life. Many scientists have said it is just RNA, so it is not life. But RNA is the building block of life. For me, the coronavirus is alive. And it is extremely intelligent. Oh, somebody would say, intelligence, how can you say that? Do we understand the coronavirus? We are looking at its spikes, but we are not looking into what's going on with the RNA inside. We truly don't understand the full mechanism inside. I believe there is intelligence in the coronavirus. Time will tell if I was wrong. In any event, this injection of the RNA within the cells, it begins the reproduction in the Golgi bodies, in the lysosome, and it decodes, it changes the code. It's like a crisp injection of a certain amount of DNA in a cell. You know, but in this case, it's an RNA. And it changes the code of that cell so that that cell is no longer producing its normal requirement metabolites. The cell now becomes a slave and produces more and more coronavirus. And so this reproduction comes to a point where there is an explosion. There may be some maybe sometimes the virus may be expulsated, thrown out of the cell, but generally it's a complete, it ends up in the complete destruction of the cell. And if that destruction happens, it should affect also the capillaries. And look what happens, it destroys the lungs. And that, along with the capillaries that are being destroyed, brings the blood into the alveoli. So pneumolysis is a new term I propose to the world. I have proposed it previously in our first meeting in India. And this is fundamental because we are talking about an agent, a biological agent that is creating a viral attack and destroying the lung cells, the most fundamental cells for survival. You see, we can survive without eating food for 1 month before we die. We can survive without drinking water, possibly around a whole week. But without breathing, we cannot survive, not even after 3 to 5 minutes. That's the fundamental organ that the lung is. Oxygen is a fundamental element of survival in life, along with the other ones. Of course, they all work in conjunction. But that fundamental element has been interrupted because of this virus in the lungs. And there it destroys the lungs. Now let's look at the terminology of pneumonia or pneumonitis that comes with these 3 classifications: bronchopneumonia from Staphylococcus aureus, alveolar pneumonia from Streptococcus pneumonia, or interstitial pneumonia from viral mycoplasma attacks. If you look at the lung here on the left, you will see that the bronchopneumonia from Staphylococcus aureus has a typical small areas where it's developing, but in varied areas in this location. The alveolar pneumonia, the streptococcal pneumonia, is localized. It was called previously lobar pneumonia because it extended through a whole lobule, and you see there it is. And then the interstitial pneumonia, that is a viral attack, and you see this blue light around the alveoli, which is just simplifying diagrammatically the interstitial area, and you see that's why it's called interstitial pneumonia. So if you look at these three conditions, the alveoli are attacked, but they are not destroyed, mostly. Some destruction may be evident, but or alveolar pneumonia or interstitial pneumonia. So the new terminology comes as a result of coronavirus. And it also comes possibly to explain SARS, because you see, we have used the old terminology that comes from the previous century. We need to evolve in the understanding of diseases of the lung. So pneumolysis is the term I propose because it means, pneumo means the lung, and lysis means destruction. And this extreme viral destruction from this terrible coronavirus means that it pulverizes the cells, it destroys the cells. Now, this destruction of the alveolo-capillary tissue, of course, brings serious compromise to the transport of oxygen to the blood. But we use in high altitude the oxygen transport triad, and we apply it now to COVID. What are we talking about? For the oxygen transport to happen, we have a pneumodynamic pump, which is the pump that moves air in and out of the lungs. The hemodynamic pump is the pump, the heart that is pumping the fluid that is blood. And this has a respiratory rate in respiration and a tidal volume. And in the heart, it has a heart rate. You see, the two pumps have a rate and stroke volume and tidal volume. They have the same mechanism because it follows physics. Biology has to respect the laws of physics. And this is circulation in a minute, and this is respiration. And this is hemoglobin. This was created by my father, this terminology. He put those names. And here we have lung destruction in this case. What is lung destruction? You see that yellow lung, suddenly it's reduced. And this reduction brings forth a reduction of the arterial oxygen content and the saturation, of course, that go linked together. In other words, if you use a pulse oximetry, you will see that the oxygen levels are dropping. And of course, at this level, ventilation still maintains the transport of the oxygen to the lungs. But at a certain point, because carbon dioxide has 20 times more diffusion than oxygen, at a certain point, because of the compromise of the lung, carbon dioxide cannot leave the lung. And so it begins to accumulate. It begins to accumulate. And that's when CO2 increases. And as it increases, gasping occurs because there is a serious compromise. If anybody has worked in a laboratory, when you are doing some tests, if you put a little bit of carbon dioxide for someone to breathe, immediately they start breathing like crazy. And that's gasping. And Professor Miserocci has well mentioned that you cannot tolerate very high levels. At sea level, he said 50 would be where I would be concerned because the value of PaCO2 at sea level is 40, but at high altitude, it's 30, you see, and that's very important. So what happens when this occurs? Respiratory rate suddenly increases, tidal volume increases, heart rate increases, and stroke volume increase. Now the heart tries to compensate the lung deficiency, but it is extremely limited in its capacity to do so. And what happens on top of this, if there's hemorrhage, if there's attack, vascular attack, hemoglobin goes down and you are in a serious compromise. So COVID-2 puts you on the summit of Mount Everest in a matter of days. Now, some people have said, oh, no, that's not possible. Yes, it is possible. Because what is going to the mountain of the summit of Mount Everest? It is going to a place where there is much lower pressure of oxygen. And if you are at sea level and then you go to the summit, you will have much less oxygen at the summit. And that's what happens here. This is the highest point tolerable in extreme hypoxia where life is possible. My daughter Natalia does not believe this. My father proposed that man can adapt to the summit of Mount Everest because there's enough oxygen to maintain life there. Natalia believes it's much higher, or maybe a little higher. So this is what happens with COVID. It suddenly goes up to the summit of Mount Everest. And what happens? You don't have sufficient hemoglobin, because if you go up slowly to the mountain, like we do, we adapt. How do we adapt? By increasing the number of red blood cells. And we increase gradually our red blood cells as we go to different camp levels. Of course, they come up and down, trying to adapt, trying to build up the red cells. So when people reach the summit, they have enough red blood cells. Messner and Haberler proved many physiologists wrong. Many physiologists said it is impossible to breathe on the summit of Mount Everest. They went up to the summit of Mount Everest without oxygen, and several others have already done. So that proves that you can survive at the summit of Mount Everest. But what happens in COVID? You see, if you don't have sufficient hemoglobin and you have a virus comes into the trachea, into the lungs, and you have this image. Look at that lesion. Now, of course, a radiologist may say, but this depends on the stage. But what I want to show you here is the surface, the amount of the lung being compromised. You see, here we can say it's beginning to be, we don't know how far deep behind it is, but we can talk about getting close to 1/4 of the compromise of the lung, we can say, assume. And then what happens? Then the disease progresses and you have half of your lungs gone. They don't work. And that's what Professor Miserocci calls, I understand, the baby lungs, because babies have little lungs because they have little bodies. But you, the adults, have these big lungs because that's what nature has given you to breathe. And so if half of your lungs are gone, you see, people can survive with one lung. It is well known, but it takes time. It isn't fast. If you take someone's one lung away, he feels tremendous shortness of breath and so on. But if you do it very slowly with disease and they compensate, they can tolerate living with just one lung. That's why nature gave us two lungs. Wisdom, like two kidneys. It's wisdom. It's the compensating factors. But what happens then? The virus can progress and take up most of your lungs. Look at this. You have almost no surface area of gas exchange. It's just on the top. So you have lost 2/3 of your lungs and you're in trouble. Now let me show you what happens when you do a pathological study. This is a pathological study, and I will tell you who gave it to me. He has reported the Mason body inside the alveolus. This is an alveoli and this is a Mason body. But you also find the red blood cells in some other alveolus. Why? Because the virus has attacked the alveolar cells. It has broken the capillaries. And we all know that there's an increase of the vascular, the vessels in the lungs in this situation. And then there's a thickened interstitium, which can be a result from interstitial edema and also fibrosis that evolves gradually. This other photomicrograph shows that the hyaline-type membrane from fibrinose, exudate, and necrotic debris of cells are found here. And there's micro abscess with pneumocystis in this area. It's an abscess. You see, that's why azithromycin is so useful, because the bacteria suddenly find a beautiful place where the immunity is decreased. There's a destroyed tissue, there is pneumolysis, and so they start to grow. So though if you give azithromycin in these circumstances, and if you give, as Tito has also explained, if you give corticosteroids, strong anti-inflammatories, but also if you give aspirin, because aspirin is an anti-inflammatory, in the beginning particularly, it can help tremendously. Aspirin is not only anti-inflammatory, it's an analgesic, it's an anti-aggregation, anti-platelet aggregation, so it avoids coagulation, and it's also an anti-thermal, antipyretic against high temperature. So it's a marvelous drug. But anyway, these photographs were given to me by Dr. Felipe de Jesus Montelongo, an intensivist, and Dr. Manuel Gabriel Romo Sanchez, pathologist from the Hospital General de Capatepec, Las Americas in Mexico, ISEM. And I thank them for this because it allowed me to interpret this. You see, this is extremely important. Pathologists have always interpreted routinely to name this pneumonia. This is pneumolysis. We have to think different. It is destruction. It is not only inflammation. It is not only the reaction of the body, the edema, but here there is destruction of the cells. And now, of course, the reconstruction of cells in the lung is still questioned. Some people have thought that cells do recover, and maybe they do, you know, with stem cells. And maybe I am even suspecting that at high altitude, we have a better recovery of the lung tissue. Now, at sea level, you see, if the oxygen saturation goes down to 90 in COVID patients, they have put them in ventilators. Whereas in the city of La Paz, at these altitudes that you see here, 4,000 to 3,000 meters, we live normally with 90 millimeters. Look at this. This is normal. And this is a PaO2 of 60. Some of the patients I have treated here, in fact, I talked with one 2 days ago. He had this very serious compromise, but the hospitals were all filled. He had some oxygen. His saturation went down to 67%. And he, with the medication and all that, he has managed to survive. At high altitude, we are more tolerant to hypoxia, and that's what I'll explain. So what is the efficiency of ventilators? And we mentioned that before, 88% of the patients on ventilators died. They lost their lives, but we won't talk about that. Now I'm hoping that Natalia is there because we have developed this graph. And this is the first time I'm showing this graph. It has been modified from the first version that I sent to Professor Miserocci. And Natalia, are you there to explain what we have worked on this?
Okay, so to give you an idea, this is a schematic graph because we haven't actually measured it, but we actually based it on what we know at high altitude. And then we looked into different papers that showed specific values that were taken in different patients, and it turns out they match. So of course we need more data to confirm this is exactly like this, but it has to be something like this. So the funny thing is that if you can see here, we have, this is very important, and why we did this, because you might think this is a very bold thing to do, but what happens is that what my father just showed you is it's something very peculiar, because you see hypoxia for a long time has been to describe all types of hypoxia. And this is, in our perspective, a mistake, because when you are exposed to chronic hypoxia, to intermittent hypoxia, and to acute hypoxia, the responses are very different. And I'm afraid there are many papers made at sea level who just talked about hypoxia, and they use this to compare this to high altitude, and the truth is that the outcomes are very different. So the interesting thing about this is that my father just showed you that at sea level, when people have below or around 90% pulsimetry, then they are sometimes put into ventilators. And for us, this is completely normal. In fact, I could right now show you how much I am having, and I will at the end of this conference. And you will see that this is completely normal for me, and it does not mean I have COVID because I had this since I was born. Maybe a little bit later because there are some changes when you are born, but still. The thing is that this is very interesting because many of you might think, oh, but you live at high altitude, so this is normal for you. In a way, yes, but also we have many people who come from the lower lands. We have several people who are in the conference who live at this altitude or who had come to, because they travel to high altitude. And as soon as they arrive to La Paz, everything changes, and you measure their pulse oximetry, and if they don't have any diseases or other underlying causes that could make them turn into this condition into a high altitude pulmonary edema or other complications, then you will see that they have exactly the same values. Now, these people, they are not exaggerating in their hyperventilation as one might think. So one day when we were talking with my father, because we have been doing this research, I told him, well, it seems like we live in silent hypoxemia. So how come is it possible that we have this saturation and we live like this, but not only us who have a chronic hypoxia exposure, but people who just arrived to La Paz and have exactly the same. So of course, this will be in relationship to several physiological changes that take some time. But the interesting thing is that something happens and it's making this possible. So our proposal is that this may have to do with the pH. Because what happens is that so long you are within an optimal pH of 7.4, which we believe is the same at all altitudes, because we need corrector factors to understand this at high altitude. CO2 arterial pressure is crucial. It's absolutely crucial. If you are within normal limits of, or if you have a proportional distribution of this in relationship to the pH, then you can keep the pH. So what we think happens is that the reason why these people have silent hypoxemia is that at first, as the virus gets to the lung and it starts spreading, it's multiplying and all this. At first, you have a shift in the pH that is starting to get alkalotic as it becomes, as it is at high altitude, but this is mild. Okay, and this has a relationship to the PaCO2 because this is much more diffusible than oxygen, around 20 times more. But then when the capacity is surpassed, this starts to move and increase, and so the pH would have a direct relationship to this. In the meantime, if we are destroying or having a shunt in the pulmonary diffusion system, then the PaO2 will be decreasing, and until it cannot be sustained. So at first, ventilation, as you can see, is not changing too much. So that's why it's not very evident. But probably if we would be able to compare the beginning and the end, you would see this difference. That's when the gasping starts. And when gasping starts, it means this is very advanced. And so it quickly deteriorates and it goes to a difficult situation and can even lead to death. So if you see, we have small points, 3 points that we have shown in different lines. These are actually based on actual measurements we found, and we think they have a good relationship. So this really has to be taken in account. We need to do measurements, but it's highly possible this is the phenomenon that explains silent hypoxemia. Thank you very much.
Thank you, Natalia. And very briefly, you see that these data, they correspond to actual cases, and this is a linear decrease. We thought it was a curve, but it's a linear decrease of arterial oxygen tension to very low levels. And these other data is also showing the points at which this carbon dioxide and PaO2 are crossing. Thank you. Thank you, Natalia. So what about COVID at high altitude? The sea level resident has limiting disability, poor tolerance to hypoxia. You see, we at high altitude residents are used to hypoxia, and that makes us stronger because we had to survive like humans and animals and plants when they're exposed to hypoxia. But if we go very fast to high altitude, we have acute hypoxia, acute mountain sickness can come when you all arrive. About 1 in 4 can have some headache and so on, but some can evolve to high altitude pulmonary edema, high altitude cerebral edema that can produce severe illness and death. So this has created a lot of fear for hypoxia. However, if you go to chronic hypoxia, you have a remarkable adaptation. And with this remarkable adaptation, we carry out normal lives at high altitude, but it requires time. Time that in COVID is not present because it is a fast evolving. It's like climbing Mount Everest in 2 weeks. You know, you need at least 100 days to really make a perfect adaptation to the summit of Mount Everest, the low levels. So you see, these are low sea level values of oxygen, 98 millimeters of mercury, PaCO2 of 40, and a hematocrit of 42. This is the city of La Paz at 3,600 meters. If you go up very fast, you come to the airport and you arrive and we measure your blood gases and you have 60 millimeters of mercury, which is a saturation of 90%, and PaCO2 of 30. And most people are doing perfectly fine. But some people can get the acute mountain sickness, HAPE or haze. However, if you go up very slowly and you take it easy, your hematocrit rises in 40 days to 50, and you have a remarkable adaptation to chronic hypoxia. So in this city, like La Paz, we are defeating hypoxia. We don't even worry about hypoxia. We live in hypoxia, but this is our normal environment. And of course, this is normoxia for us. If we are born here, as I was, Natalia, I delivered Natalia, by the way, with my father. I delivered my 2 daughters and all the family children. At high altitude, Tibetans have apparently a lower hematocrit than Andeans, and they say that they're better adapted to high altitude through generations. However, have a lower hematocrit than men. Are they better adapted to life? We don't think so. We are the same. We're both adapted to life. We just have different adaptation methods. Every living being, according to the genetic buildup that determines their species, biological characteristics, and sex, has an optimal form of adaptation, and the proof lies in a successful reproduction and survival at any altitude. This is a very important concept. Now, we, the inhabitants of the Andes, are perfectly adapted to high altitude through different mechanisms. Disadvantages with the Tibetans. We have to invite them to play a soccer game, as we have done at 6,540 meters in the Mount Sahama. Let's see who does better. This is the increase of the hematocrit from sea level when I was in Copenhagen all the way to La Paz. You see, my hematocrit normally in La Paz is 50%. Half of my blood is filled with red cells here in La Paz. That's my normal hematocrit. I went to work actually at the University of Copenhagen, and when I came back, it was from 36, it went in this curve. In 40 days, I achieved my normal hematocrit. And this then I received full adaptation. Some people can get acute mountain sickness the first 2 days, 3 days, or hyperhaze. But in this area, you get tired of going up the stairs. However, after 40 days, when the red blood cells increase, we have a normal life at high altitude. But some people can present, of course, polyerythrocytemia, which is chronic mountain sickness.
To as excessive erythrocytosis, but we think that's wrong. It's adaptation. Referred
formula that we have created with my father. My father was the originator of the idea. Adaptation equals time over altitude. Very important for many aspects. And he proposed that man can adapt to any altitude, even the summit of Mount Everest. He said that the organic system of human beings and all other species tend towards adaptation to any environmental change within an optimal period of time and never tend towards regression, loss of adaptation, or de-adaptation that inevitably leads to death. If you lose your adaptation, you die. You cannot live at high altitude with a loss of adaptation. It is very common to see papers where they say this patient has lost his adaptation and he lives there 15 years. You cannot lose adaptation. Adaptation, that's his concept, has to be the mechanism of survival. This man living in La Paz was 123 years old, according to the press, at high altitude, at 4,100 meters. And so I asked myself, does man live longer at high altitude? And yes, he does. This is based on the Bolivian data obtained from all the records of Bolivians, going from Pando, the lowest area at 221 meters, all the way to Potosí, the highest city at 90. This is the city of La Paz. Look how the curve goes up. We live longer at high altitude. And that was the greater than 100 years, and these are the greater than 90 years, divided by population, of course. And in Sucre, it's the highest level. And you see, when we compare the older than 100, is the orange columns, and the gray columns are the greater than 90 years of age. And this has a population, Santa Cruz at 410 meters, it has a population of 2.7 million, the same almost as like La Paz, very similar. And look at the difference of the longevity. So we live longer. And the carbon dioxide in our laboratory doing blood gases shows that our PaCO2 is located at 30 millimeters of mercury. If you compare that with sea level, normally it's here. But look at the curve, look at the distribution. We don't have high CO2, which brought us to the following observation. You see hemoglobin in relation to high altitude. If you are at sea level with a PaO2 pressure of oxygen at 100, then your hemoglobin can be 14. Of course, in India, people have lower hematocrits because they are they're mostly vegetarian, and they don't have the levels, the normal levels we have here in South America. And so at sea level, and then when you go up to La Paz at 60 millimeters of mercury, you have 16. Mine is 16, my normal hemoglobin. And as you go up higher, this is based on population studies, it goes up. So hemoglobin is a fundamental factor of adaptation. And in the Mount Everest, it's estimated to be 26. Professor Kolar from the Czech Republic has proved in animals adapted in rats and adapted to the Mount Everest altitude at 8,000 meters, they have a PaO2 of exactly 30 millimeters, with a PaO2 30, they have a hemoglobin of 26.5, very similar to what we estimated. And here is the COVID. The COVID is right here, going in the wrong direction. They don't have hemoglobin, and in fact, they become anemic in several cases. So they are going in the wrong point of hemoglobin. And this is carbon dioxide. Look at sea level, it's 100 millimeters of mercury. And as in La Paz at 60 millimeters of mercury, it's 30 millimeters less. And in Mount Everest, it's around 8 millimeters. This has been studied and proved, but oxygen is around 30 millimeters. We're talking about carbon dioxide on this scale. So carbon dioxide goes down, hemoglobin goes up, and look what happens in the COVID with carbon dioxide. It goes up.
So on these two factors, fundamental factors, we have based the tolerance to hypoxia formula. A fundamental formula to understand in these circumstances COVID. Transcendental indeed.
Have destruction of their lungs and less hemoglobin. If you reduce the hemoglobin, you have less tolerance to hypoxia. If the PaCO2 increases, you have less tolerance to hypoxia. So those are two crucial factors of the tolerance to hypoxia formula. So at sea level, if you are to hypoxia, when you go to the summit of Mount Everest, you are 6 times more tolerant to hypoxia. Unbelievably, this is a paradox, but nature has provided the mechanisms. So now I will talk a little bit about this paper, Extended Longevity at High Altitude Benefit Exposure to Chronic Hypoxia. There I said that ultraviolet rays have sterilizing effects on bacteria, and it is highly probable that they are beneficial at high altitude. This was in 2017. I believe I have been the first to say that high altitude has a protective effect thanks to high radiation of ultraviolet rays. The Andean condor and COVID, he flies at 6,500 meters, a very large animal, the largest flying bird in the world by combined measurement of weight and wingspan. And you see, this is his eye, a very good vision, and this is the coronavirus. And so the view from his eye gives a different point of view in these circumstances. So that's why I wrote a paper. We wrote a paper here, first author, Natalia is the second author, to Pil Venkatesh from India, Kushal Das from India, and Jorge Solis from Canada, where we say COVID-19, multiple diseases simulating extreme high altitude hypoxia. Look at this. This is May the 5th. We were one of the first to talk about multiple diseases simulating extreme high altitude exposure, oxygen transport physiology, and scarce need of ventilators. That's exactly what Professor Miserocci has said. That's exactly what he has said. The importance of this scarce need of ventilators is truly crucial. And we said it in May, and now it becomes more and more evident. That's the Andean condor's eye view. La Paz has this ultraviolet radiation index. You see, like this, winter low and high here. And in summer in Copenhagen, where I was there, it goes up, but look, in Copenhagen, it reaches this moderate level of ultraviolet index. In La Paz, we live in the very high extreme ultraviolet. And so that's why I proposed that it would be protective for coronavirus. And it was. Several papers have come up, and I don't have the time to show you those, but this is the lowlands in Bolivia, Santa Cruz at 400 meters. Look, the virus arrived at the same time, exactly at the same time. And look, this is the Santa Cruz, the lowlands, the tropical areas. Look how fast it went up. But this, the line, break line at the bottom is La Paz. And in La Paz, you can see, look at the difference. It was very slow in presentation. But what has happened with time? This is Santa Cruz, and it has begun to increase at high altitude. You see how high it's going now? Still lower. But August 15, it was at that level. And so this is from Weather Online, the ultraviolet radiation index in La Paz, Bolivia at our airport. You see that from April, July is the lowest point, August, September, it re-increases again. So in winter, we have lower ultraviolet radiation. And what I did was to put the ratio of Santa Cruz, the lowlands, with La Paz, because at some point, they were 14 times more cases in the lowlands than in the highlands. And it increased like this. And then it started decreasing. The difference started decreasing. And this is El Beni, another place in Bolivia, another city with much less population, of course, 130 meters above sea level, And compared to La Paz, the ratio, but look at how beautiful this is, because this is the ultraviolet radiation. It has come down to the lowest level, and that corresponds to the highest peak. And now that it's increasing with the days, because it's coming back, we're going to finish our winter, there will be a change. I am certain that will happen. And then we published this, does the pathogenesis of SARS-CoV-2 decrease at high altitude? Actually, this was written by Christian Arias and Jorge Solis, and we participated as co-authors. And all of these are Bolivians. And this is focused on another point, fundamentally, of the ACE2 receptors being reduced at high altitude. We also put our part in relation to the ultraviolet radiation in this paper. But I want to show you, and this is for Dr. Calderon from Peru, whom I invited to come to this talk, because he talked of the incidence being increased at high altitude. And I agree with him, it has increased tremendously, but it was slower at the beginning. And this is by Dr. Nestor Freddy Armijo Zubieta, who has given me this information. And look, this is the incidence of by altitude. And you can see this is the lowlands. These are the lowlands, the valleys, and the highlands. In the lowlands, we see that 43% of the cases of the incidence from the lowlands, and then the highlands, 35%. You see, it's still a tendency lowers, and these are the populations. So this is the highlands, and these are the valleys, and these are the lowlands. The highlands have much less. And look at deaths. This is very important. Do we die more at high altitude? We are in a hypoxic environment. This virus attacks our lungs. Do we die more? No, quite the contrary. We die less. Look at this. Again, the lowlands, they have 46% of the deaths. The mid-valleys, 30%, and at the highlands, and here's the city we live in, it's only 22.9%. So I'm very proud to tell you that high altitude does protect us. Now, there are several factors. And look here, the mortality rate by departments. These are the different departments in Bolivia. The overall death rate in Bolivia is at 4.1, according to this last date. And you see the amount of deaths are much higher in the lowlands in green, in the valleys, and then in the highlands. So why and who gets more severely the COVID-19? Depending on the genetics, the lifestyle, the nutrition, exercise or sedentary, obesity, dehydration, sex, may I add that Dr. Danuska has said, inflammatory processes, processed food, exposure to toxic substances such as insecticides, chemical fertilizers, medication they receive. You will hear some beautiful talks about medication and the hypertensive drugs tomorrow by Dr. Murray and Dr. Jim Russell. Chronic diseases, previous exposition to other viral, parasitic, fungal diseases, bacterial, area of major compromise of the lung, viral pathogenesis, and old age and hence organ deficiencies, and many other aspects, as you know. So this was another article that Jorge Solis has written with all the collaborators, and most of us are Bolivians, by the way. Matthias Dutchman is from Australia, and the rest, we are all Bolivians. Coping with hypoxemia, could erythropoietin be an adjuvant treatment of COVID-19? Well, our next speaker will give us more details of his work at the Max Planck Institute. For the more severe cases, we recommend erythropoietin, and we recommended this in May already, be injected in the vein as soon as the symptoms begin in these severe, more severe cases, and then 3 days later, repeat the dose. Why? Because we want to increase the hemoglobin, the fundamental transport molecule. And we at high altitude with lower oxygen, we have more hemoglobin. That's why we propose this. It gives us more tolerance to hypoxia and more chances of survival. You could also give blood transfusions. This is another article that Christian Arias Reyes from the University of Laval has written, and with different authors, and we have been also co-authors, but he has been the fundamental scientist working on this. Roberto Alcinelli is here also, and Matthias Dutchman from Australia. And here's Jorge Solis, of course. Many of these are PhD students. Decreased incidence, virus transmission capacity and severity, and you heard his talk yesterday. Now these are just, I'm finishing now, showing you some tests. High altitude diving in Lake Titicaca. Here I'm working with Paul Erik Paule at the University of Copenhagen, you see, with hydrogen ions, and working at our clinic in the first high altitude chamber with Luis, my brother, my father, with the high altitude chamber, studying ventilation and treating patients with high altitude. This is our Chacaltaya Pyramid Laboratory at 5,265 meters. And with our camper, we can go up and do tests. And this is the second chamber, second version that we now have our institute. And we manage people with less oxygen, and we're able to interpret it. This was our seventh chronic hypoxia symposium, IPPA. This is from the Armada Boliviana, the Bolivian Navy that supported us, the University of Laval, University of BLDD, and our Zubieta University. You see here, we are studying a stationary bicycle. He was a good sportsman in biking at 5,300 meters. So we are here on planet Earth, and we're going outside of Earth.
And this knowledge of chronic hypoxia will allow us to travel in space and have biology surpass physics with the word biospace forming. It is the adaptation of all living beings on Earth to space, fundamental.
Thank you, Dr.
Yes, you're certainly welcome.
Every time I listen to your talk, I get feel when we go to the patient, this is what was happening. And you told this almost 2 months back when you presented for the first time. So
yes.
this is a enlightening talk for many clinicians, particularly when the pneumolysis happens. So how the intubation may not help. High PEP may damage. So this is an enlightening thing, and it will help to save a lot of patients. Thank you, and I will take on the questions now.
Thank you very much.
I'll read the question.
Doctor, how is your idea normalized as a function of number of viruses, number of PSBC tests, age, loss of smell and taste in patients, cell culture response to virus at low and high altitudes? Has it occurred at the time of outbreaks of other viruses at high? I suppose it means at high altitude. High altitude definitely reduces the number of viruses infection because of the ultraviolet effect and other things, ozone and many other things, the temperature changes and so on. We've had, of course, some patients loss of smell, but not very many, to be honest. I haven't heard many lose smell. I've heard some, but not very many.
Okay, there is another question. What is the mechanism for hypoxia leading to pulmonary edema in patients with high altitude pulmonary edema?
The mechanism for hypoxia?
Yes.
Okay, well, there you see when oxygen drops, when you come to high altitude, you increase the pulmonary pressure, pulmonary artery pressure. And if you increase the pulmonary artery pressure, then you can really have a stress failure of the vessels, and there will be an inflammation. It has to, I have also said that maybe there's viral implication in the lungs of the people that suffer high altitude pulmonary edema. Yes, there's some degree of that, I suspect, but it's a lesion of the alveolus. Anything else?
What is the blood pressure changes with respect to PaO2?
I'm sorry?
Blood pressure changes with respect to PaO2.
To PaO2. At high altitude, we have a tendency to lower blood pressures. Except the first days when you come, you can have a little higher pressure, but then we have normally much lower pressure than at sea level. And that has to do because the organism has to concentrate the blood pool in the fundamental organs of the brain, the hearts, and the lung. And so it reduces peripheral pressure in general.
There is another observation. The people who lives in L alto has more mortality than people who lives in L bajo.
No, they have lower mortality, much lower, in fact.
Okay. Sir, as we discussed in COVID, will high altitude also protect a non-COVID patient with any chronic condition of lung, with altered PaO2 and PaCO2 or any hematological condition with low hemoglobin?
No, you can't have low hemoglobin. If you have low hemoglobin, you lose the tolerance to hypoxia. You have high hemoglobin. That's the compensating factor. That's fundamental.
Thanks a lot, Professor Gustavo.
Thank
It was
you very
like,
much.
it's
I'm sorry
always
about
enlightening.
the time aspect.
Thanks a lot. It's always enlightening. Okay, listening to you, and it's the concepts are very, very clear and simplified the way you present.